The biggest thing is when you have pain with bowel movements, especially around your cycle. That is a huge thing in endometriosis. And so I think any pain that you notice is worse with bowel movements around your cycle, that can be bowel endometriosis. The medical management of endometriosis requires an insane amount of creativity. You can't always outsmart your endometriosis if it's there.
I've heard this phrase so many times from women. Going to the gynecologist is preparing for war. You need to get your shield. You need to be ready to battle because they're going to gaslight you. They're going to dismiss you. They're going to try to force you on a medication you don't want.
I think there's a significant lack of training for chronic pelvic pain and endometriosis. They just don't know. The doctor not being knowledgeable, and they get kind of defensive if they're like, I don't know what's going on. You're supposed to get better on the pill. And I think it's just like a lack of education on our part.
Dr. Ingenito
is on a mission to change how we treat and talk about pelvic pain. A Denver-based specialist in endometriosis and chronic pelvic pain, she blends evidence-based medicine with fierce patient advocacy.
Using her platform at Dr. Pelvic Pain Do to empower women with knowledge, compassion, and real solutions.
When we think of misinformation, the problem is not the rise of influencers. It's not the reach of influencers. It's not influencers at all. It is doctors who have neglected women, who have created this gap, and who have forced patients to go outside of the medical community to look for advice.
Most of what I've learned is from Instagram and watching my own podcasts. I started treating more PMDD. I think I saw some reel about treating PMDD more with the hormone replacement therapy type meds. And I have seen such drastic results as opposed to doing things like putting people on the birth control pill. But that ain't gonna be enough if somebody has.
Welcome to the Dr. Brighten Show, where we burn the BS in women's health to the ground. I'm your host, Dr. Jolene Brighten, and if you've ever been dismissed, told your symptoms are normal or just in your head, or been told just to deal with it, this show is for you. And if while listening to this, you decide you like this kind of content, I invite you to head over to drbrighten.com, where you'll find free guides, twice weekly podcast releases, and a ton of resources to support you on your journey. Let's dive in. So many women, if not all women, have heard that painful periods are completely normal. How can someone differentiate between what normal period cramps are and what is something like endometriosis?
Sure. I think one of the most important things is starting with just your basic over-the-counter ibuprofen or nonsteroidal anti-inflammatory. And if that really doesn't cut it in terms of helping with your cramps or your pain, then that's a red flag that something could be off. And that for me is a red flag for endometriosis. The other thing is that if you're having more than really bad cramps, you're having pain outside of your menstrual cycles, that's also a big red flag. Certainly if there's any family that has endometriosis and you're kind of seeing the history repeat itself, I would say more than likely it's endometriosis.
When you say pain outside of the period, what are we talking about specifically? Because the pelvis has a lot going on. There's more than a uterus there. And so sometimes people are like, oh, is it IBS? Do I just have gas cramps?
I would say anything that you think doesn't seem right is probably worth talking to your doctor about. Pain with ovulation, that's a big one too, that I think a lot of people dismiss as just a normal part of cycling, but pain with ovulation is another big one. And any consistent like patterns that you can find different times of the month with bowel movements, urinating, that kind of thing. I think those are all kind of red flags for me.
What I'm hearing from you is that you should listen to your body and trust your intuition.
That's a big one.
So you brought up the bowel movements. What about bowel movements points towards endometriosis?
The biggest thing is when you have pain with bowel movements, especially around your cycle. That is a huge thing in endometriosis. And so I think any pain that you notice is worse with bowel movements around your cycle, that can be bowel endometriosis.
Okay. What's bowel endometriosis for people who are like, I've heard this before?
Endometriosis that grows onto the bowel, so small intestine, large intestine, usually seen in more advanced disease, stage 3 or 4 endometriosis, where those lesions have implanted throughout the bowel.
There was just someone I got a comment from this week, and she had said to me, I look back now and I realized that before I even got my period, all of my digestive issues were linked to endometriosis. And she said it wasn't just bowel, but I had upset stomach. I was being diagnosed at 9 years old of them saying like, oh, we think that you have reflux. And she said after I had my excision surgery, which was decades later, all of the digestive symptoms resolved. What's going on there?
So I think that speaks to the prostaglandins and just the effects that it has on your gut. And so that inflammatory process can cause all of those things that you just mentioned. I just had a similar patient who had like decades of nausea, only to find out that after excision, her nausea went away. So I think a lot of it is a bit retrospective and everyone's a little bit different. I think we'll know in the future as more people come out with these stories and as we get some more studies out there that potentially there's a lot more that we can see even before the onset of periods. So I think that's not usually the most common thing, but I definitely have seen people who have unrelenting nausea that can't really get that to go away until they have surgery.
Yeah. When this person commented to me, it raised my eyebrows because I had chronic gastrointestinal symptoms, like starting very young. And I was later found to have H. pylori. They were like, oh, that's the cause of everything. But even after that, they were like, oh, you're just going to stay on proton pump inhibitors for the rest of your life. Like, this is just the way it is. And I look back at all of that and I'm like, oh, little flares from the body that it possibly could have been connected. You said prostaglandins. Not everyone knows what that term is. Can you explain what prostaglandins are and why they're involved with this pain, this nausea, and these bowel problems?
Yeah, so prostaglandins are an inflammatory substance that can cause things not to work properly. It's basically what it is. And those prostaglandins are released in endometriosis, and that kind of sets off this inflammatory cascade that causes other parts of your body not to work properly.
The prostaglandins, they're not always all bad. So we know prostaglandins are important for women being able to deliver a baby. They're important. They're part of how we shed the uterine lining once a month, but they can go wrong in endometriosis. So what's going on there? Are you saying the lesions themselves are making prostaglandins?
So yes, some of the lesions will make some prostaglandins, and those can be at just higher levels than you would normally see with your normal processes like labor and delivery and having your period, endometrial lining shedding. So I think that there's just a higher level of prostaglandins that cause a lot of inflammatory problems.
Yeah, can I just like highlight what you just said there? Because women with endometriosis will say, I'm having cramps and pain that's like being in labor. And doctors will say to them, no, you're being dramatic. But if you have lesions, which could be anywhere in the body, making prostaglandins, which are causing these contractions in labor, it's totally conceivable. Would you agree that you could have period cramps that are comparable to being in labor?
Agree. That is the couple times that I experienced labor, I would say if that's what you're experiencing, yes, it's definitely a prostaglandins process.
Do you have endometriosis yourself?
I do not have endometriosis myself. I get that question a lot. I do not. I think I've just learned a lot about it over the last 15 years from my patients. So I get that question. People think I have it too.
No, I just was curious because so I have had 2 unmedicated births. And I remember the pain as a teenager, but also the pain after my 3rd egg retrieval. And I was like, oh my God, like I kind of could have taken an epidural during labor, but like the endometriosis pain, I'm like, sign me up for an epidural. Like that's like how intense it was. So that's why I was just curious because you're like, I've been in labor a couple of times.
Yes, it's an intense one.
Yeah.
Intense pain.
So with these lesions, there's this idea that has been perpetuated for a long time that it's just the endometrial lining that has been spread via retrograde menstruation. What do you wish people actually understood in terms of the current research of what it tells us about endometriosis?
I think that the biggest things we see it a lot of times from birth. Those lesions are present and we don't really know why. And you're born with them. I think there's also a lot of research now coming out about retrograde menstruation that I think that was probably just the way they understood it however long ago, the best that they could. And I don't know what we're going to know in the future about it, but I think that was the best way they could conceptualize like how this was. And then that theory just kept going and going. But the newer research, shows that it may be present in female fetuses or male fetuses in rare circumstances, and that those lesions develop as you go through puberty and start to develop.
Yeah. Yeah. And you see the retrograde menstruation was also born out of the idea that it's just the endometrial lining, but these lesions are distinct from what our uterus is doing month after month. They've kind of got their own agenda. Can you explain why these lesions are different?
Yes. So these lesions respond differently to things like prostaglandin, estrogen, progesterone respond differently to hormones. A lot of times if we use medications to treat endometriosis, we can treat the endometrial lining, but we don't always get the same response from the endometriosis lesions. They just have a different way of behaving than the endometriosis or the endometrium in the uterus. And so that's really where I see the struggle is a lot of times we're using medications and we're using those medications. We're expecting the same response that the endometrium would have. And in endometriosis, we're just not getting those results. We can't quite get those lesions to respond like we would.
When you say medications, what medications are you talking
Different
about?
hormonal medications, different anti-inflammatories, really anything that you can do to treat endometriosis, I feel like.
You're like, any drug, it's all bets are off.
I mean, we use like the endometrium. Okay, this works on the endometrium. This works for this process that's based on the endometrial lining in hopes that'll help us with the endometriosis type lesions. But I just don't find that it's always as successful. I think the medications work a lot better once you've had an excision as opposed to beforehand because they're just not responding.
So is this why so many gynecologists believe that the birth control pill is like a gold standard treatment for endometriosis? Because they're like, endometrium, it works on that, therefore it would work on a lesion, even though we see so many patients report that it's not enough. There's certainly some people get some relief from it, but by far the majority of women that I have spoken with, that I've seen as patients, that even myself are like, no, it's not actually addressing what's going on for me.
So in training, in medical school and residency, I would say there's a significant lack of focus on endometriosis. I mean, I think probably less than 5% of my training was focused on endometriosis. There's just so much that you have to get through. I don't think in 4 years, at least in the United States, that we have enough time to actually focus on endometriosis and chronic pelvic pain. Everything that I learned that I do now, I learned after my residency. And I kind of had to unlearn what I learned, right? So the basic things that I learned were ablation and the birth control pill. And there really wasn't time or there wasn't anybody focusing on that in the training. So I think there's just such a wide variety of information and procedures and safety and just things that we have to take in those 4 years. And a lot of it does have to become repetitive, right? Like doing deliveries, like you need to be able to do those in the middle of the night and you need to be able to do back to back and still function and keep people safe and healthy. That I think endometriosis is just not a priority in training. It's just not. So I don't even, if someone has gotten that far, a gynecologist to say, this isn't working because the endometrium doesn't work like endometriosis lesions, that would be novel thinking. But that is not an idea that's presented.
Yeah.
But yeah.
I know it cracks me up when I get attacked by gynecologists online when I'm talking about doing imaging. I'm talking about anything that is accepted by endometriosis surgeons, people who actually specialize in it. And these gynecologists come with such ego about how they know so much more. And I'm like, and I see how for me, I'm like, okay, I get where you're coming from and I can understand this. And I think because I am a medical professional, but I see when these interactions happen with patients and how angry patients get, but also how so many more patients who have endometriosis know this condition, the disease, and the research better than their gynecologist, but they're absolutely dismissed and gaslit about it.
Yeah. That's a huge problem. The training and the education does not exist. I think I can remember like all of the laparoscopies that we did for endometriosis, either just looking or ablating. Never, I don't think I did an entire excision the entire time I was a resident.
Oh my gosh.
I've been out for about 15 years. But still, I mean, these are your like middle-aged gynecologists, like serving the population. And I think, again, it was just pretty much birth control pills and then use them continuously to see if that helps.
Yeah.
So I don't think many people take the time to learn about endometriosis on their own, let alone chronic pelvic pain. I think, and that's because the education is just lacking. That really has to come from the gynecologist wanting to know more about it, wanting to help their patients, which is kind of what happened in my situation. Was like, what is going on with these women? And like, how are we going to help them get better? We can't just keep doing the same things that we've been doing. So yep, you're right. That's exactly where we stand, is the patients often know more and are more educated. But I think if we get more education and more of a focus on endometriosis, at least for a part of the training, I mean, even like a couple months with a chronic pain specialist would be helpful.
Yeah. I also think, and I believe this to be true, and other people I've had on the podcast say the same thing, is that there's too much of an expectation on gynecologists for what their scope is. Like, it's just far too much to expect that you are an expert in pregnancy, in delivery, in managing someone postpartum. And then you also have to be an expert in chronic pelvic pain, in hormone therapy management. I mean, we know gynecologists are also not competent in hormone therapy management. They are good at birth control pills, which I always laugh because when they're like, no, we're hormone experts. And I'm like, knowing the pill it's helpful, but it's not a hormone expert. And I think it's hurting women. And I think that this is not an individual doctor problem. This is at the root of it is that medicine is like, meh, it's a woman, just toss it all in this bucket. And there really should be subspecialties beyond just general OB-GYN. What do you think?
I agree. And I think most of us find that as we start to work with women, like in the process of their career. As you start to work with women, you kind of see like, okay, I feel like I connect with this. I feel like I'm interested in this. I feel like I can help this person here. But yeah, I mean, it's all, and it's like you're drinking out of a fire hose when you have like a resident, like it's insanity. And you're working, ridiculous hours, like you can barely take it in. And we're also like, we're learning oncology. So this is just such a broad field. And I've always thought that like obstetrics should be a different residency than gynecology, and it shouldn't even be the same, but let alone like the things that you see in gynecology. I mean, there is no real good training on hormone replacement therapy. Most of what I've learned is from Instagram and watching my own podcasts and like TikTok. I mean, honestly, like I started treating like more PMDD. I think I saw some reel about treating PMDD more with the hormone replacement therapy type meds. And I have seen such drastic results as opposed to doing things like just putting people on the birth control pill. I mean, so it's just a little bit of trial and error, and it's a little bit about learning about it. And for me, that kind of came from just having all these patients that, have had endometriosis, have had all these surgeries, are in surgical menopause, and learning more about hormone replacement therapy.
I appreciate your refreshing honesty. It truly is refreshing, because I think sometimes as doctors, like there's this like fake it till you make it right kind of mantra where it's like, I have to always front as I'm the expert. But until we actually say like, these are deficits in my training, we can't fix those things or start to improve our own education. I mean, my education, I've been prescribing hormone therapy for over a dozen years now. And I'm so grateful because in my rotations, my attending was in perimenopause. So she's like, you better learn this. You better know this. And we were actually taught all of that. And learning only in the last few years that gynecologists weren't taught about hormones at all, really, it made so much sense of how often I got a gynecologist being like, you're going to give her cancer and kill her if you give her hormone therapy. And I'm like, in the case of PMDD, she may take her own life if we don't come in with interventions. Like, there is always a risk and benefit conversation. And while you're scared, because the Women's Health Initiative definitely scared everybody, like there's nuance to this conversation. I want to talk more about like guiding patients through like how to find a provider. But in this conversation, something I'm curious about is what inspired you? What made you go down this road of chronic pelvic pain and endometriosis?
Sure. I'm grateful like to work in an organization that's a large group. And we had one chronic pain specialist for this very large group, this very large population of patients. And in that, I found myself like sending a lot of patients to her, which is what happens to me now. But there are a ton of gynecologists who just are not interested in this or don't know what to do beyond getting an ultrasound and starting somebody on the pill. And so for me, I was referring someone to the specialist who had 6-9 month wait lists.
Oh, wow. Yeah.
Right. And then I was kind of found in this pickle. I was in this middle of it where I have like 6 to 9 months to try to help somebody. So, and I just felt like there was really a huge gap. And I felt like this was a population that could really use some help. So that's kind of, I just was like, these people need help. I think a lot of people can do a lot of basic things in OBGYN, but I was like, I think that I really could make a difference here in helping others and managing chronic pain. So it was something that was interesting. It combined both medical and kind of surgical therapies. And so I just took interested in it and started going to the conferences and learning from her. And that was it.
Yeah.
So I felt like there was just such a significant need. It was also nice for me because I was, to be honest, learning something new about 5 years after I finished my residency. So it kind of felt like learning something new.
Yeah.
And I saw people getting better. And so I just felt like, why are these people waiting 6 to 9 months, you know?
Yeah. And I really appreciate somebody in the endometriosis community. I appreciate you seeing the need, stepping up, especially, 6 to 9 months. There's going to be women listening to this. I know women in Canada are waiting like 2 years. Like there's a global issue in endometriosis and people not getting relevant care. And it is something that I had somebody reach out from the Netherlands and they're like, can you come and speak here and talk to doctors about this? Because they think just the pill or do ablation and like we're not getting the care we need. So with that said, what's the first step someone should take if they suspect endometriosis? Like first thing, someone's listening to this, they're like, oh, this pain's not normal, this bleeding's not normal, like this is not normal. What should I do?
Good question. I think keeping a diary, obviously, of those symptoms and going in with a diary, especially if you've got 3 to 6 months of data to bring forth. It's hard for me to say what the next best step, because I would say, go see a doctor. But I think I'm really cautious because if you see the wrong person and you end up getting dismissed or somebody who doesn't know what they're talking about, then you internalize all of it. And then it becomes this big thing mentally where you're like, I'm fine. This is normal. They said it's fine. So it's just hard because I feel like that first touch, maybe even then you're brave enough to get a second opinion, especially if you're really young. Maybe you don't even know to advocate for a second opinion.
Yeah.
So, I mean, I feel like you've got to find someone who has an interest in endometriosis, but how you find that person, it's challenging. I think if you have a family member that can advocate for you, I think that's really important to bring them to that doctor's appointment. And then persistence. Like I really think that if you feel like you have endometriosis and you're getting an answer from a doctor that doesn't sound right or just sounds like they don't know what they're talking about, I would just say, is there anybody else you could send me to? But it's hard because I feel like a lot of these first touches are kind of when things can go really downhill.
Yeah.
And then they see the doctor has a limited amount of time. They order an ultrasound, recommend the pill, and you never talk to them again. So it's tough. I feel like, it's that way with a lot of medical conditions. You can't just walk into anyone's office.
Yeah.
You've got to have done your research, which is a lot of work.
It's so much work, especially when you are in pain. And this is something that I think about all the time because, you've probably had your own experiences. I talk so often to female colleagues. We get gaslit. Being a doctor doesn't protect you from getting gaslit. No. We get bad information. We know we've got to get second opinions. We're navigating more stuff and we're losing time. We're losing time with our family, time feeling well, time just living our life, time bringing our talents into the world. And it is so challenging because I often think if I didn't know what I knew, where would I end up? And I have so many female colleagues that are just like, how does the average patient do this when we know what we go through, but we have the knowledge to know that someone's wrong?
I don't know. I really don't know. I sincerely struggle with this in my own personal life, and especially advocating for like my children and what they need. And I hear it all the time. I get thousands of DMs like this doctor said this. And I honestly don't know. Like, I think one of the best things you can do is bring an advocate with you because sometimes that person can kind of rephrase what you've said. And be, a lot of times I've had significant others stand up and be like, this is like ruining our life.
Yeah.
Like, she can't work. She's missing school. She's never going to get into college. Like, I think when they kind of stand up and make those statements, it's really like, I'm like, okay, I believe you.
Yeah.
And I think people come in very defensive talking, and I'm like, well, no, when you're here, like my first thing is I need you to basically talk me out of endometriosis because a lot of what I'm seeing is chronic pain and a lot of it is endo. So I'm kind of listening to your story thinking you need to tell a story that doesn't tell me it's endometriosis. And so a lot of people come in with like these advocates. And so I'm like, I'm safe. I believe you.
Yeah. But it is something that I think a lot of doctors, so they won't say this on camera, but they don't want to work with women who have chronic pain because they say they're mean, they're reactive, they're mean to my front desk staff. And the thing that I'm always like, you have to stand back and you have to think about, this isn't your average patient that you just go into this visit with. There has to be a setup ahead of time of like, we know that this has been a struggle for you. We understand that you've been with providers who are not going to listen. This is how we're going to do things different so that you're held and you're supported and that you are in partnership with us. And it's that, you know, I am in a position where I teach doctors at medical conferences. And so when I teach people this, I mean, I get messages from doctors who are like, oh my God, like 180 on my patients. I'm like, yeah, you have to like set up the expectation for the person. Sometimes it's even on your schedule so that they understand. Otherwise, you know, I've heard this phrase so many times from women just in general, is going to the gynecologist is preparing for war. You need to get your shield. You need to be ready to battle because they're going to gaslight you. They're going to dismiss you. They're going to try to force you on a medication you don't want. And this is how women as a whole start to feel. So especially when you're a chronic pelvic pain patient who's seen 10 doctors who've done that to you, that expectation is kind of there. And I think, you know, for patients who are listening, I always want people to know that like, you've got to give a doctor another chance. Like, don't judge them before you get there, but also not everything should fall on the patient's shoulders, right? To speak the doctor's language, to make sure you're holding the doctor's ego in mind so that they don't get upset with you. Like, it's a lot for one patient.
It is quite a bit. That's why I try to come in with a very, very limited ego, listening and kind of helping you where you're at. And one of the things that I always ask people is like, what's the one thing you need to leave my office today with? You know, and sometimes they say strange things. I'm like, okay, we can accomplish that. And other times I can't accomplish their goal. I'm like, I'm be completely honest. We're not going to be able to accomplish that goal here. And to be honest, most of them have very realistic goals. And it's like, can you tell me if you think this is endometriosis?
Yeah.
What would you do next?
How much do you think medical trauma is contributing to mental health issues among women with endometriosis and maybe even perpetuating pain?
I think a decent amount, because if you have constantly like going in with a shield, like you explained, that's hard. I mean, I feel that like anxiety sometimes when I have to go in and advocate for my child. It's just a lot, and it's a lot of stress. And so if there's just someone there to meet you, like to take all that off, like, I believe you. I think this is endo. Like, you don't need to, like, this isn't, you know, not a court case. I believe you. But I think that leads to a lot of anxiety, which is where I say, like, every single touch that you have can just bring more and more anxiety to the table. And the more doctors you see that dismiss you, I think it's just a cycle. I do think it lends to a lot of mental health issues for patients with chronic pelvic pain. And I think though chronic pain already disposes you to anxiety and depression and those things, self-doubt.
Yeah. Yeah, I had a guest on, I'll link to his episode, Justin Janoska, and he works with a lot of women who have autoimmune conditions, and he talks about how medical trauma is so difficult. It's such an obstacle for people to be able to actually fully heal, because they have to partner with these doctors, but they are in a abusive relationship sometimes with their practitioner in the way that they're being treated. And so they can't really heal because of resources, because of insurance, because of all of these things, because every time they have to meet with that provider who they need, they're like bringing up more trauma, more injury, more wounds.
Yeah, I think at least in the U.S. health system, I think it's a bit broken. I think the doctors are also really limited. Like for a lot of us are really limited on time. Some people have the grace of 2 hours for their consult, but a lot of us are really limited on time. And I think that is at the detriment of the patient, especially when you have a chronic condition. So
why do you feel that endometriosis is notoriously so hard to diagnose? And it is not just patients struggling to get diagnosed, but providers believing that this is some rare condition. So why is it so hard to get the diagnosis?
I think it comes back to the training that we get. I think there's a significant lack of training for chronic pelvic pain and endometriosis, and they just don't know. So I think the doctor not being knowledgeable, or whoever you see not being knowledgeable, and they get kind of defensive if they're like, I don't know what's going on. Like, you're supposed to get better on the pill and your ultrasound was normal. I think it's just like a lack of education on our part. Most OBGYNs have to unlearn what they learned in med school and residency to know how to properly take care of these women. So I think this goes back to like a lack of education in this space in medical training. And at the same time, I think we also lack really good non-invasive tests to be able to say this is endometriosis. I mean, it's one of those conditions where to make the diagnosis, you pretty much have to have confirmatory surgery. So we don't have a good tool. There's no good tools, and there's a lot of people who do not know about endometriosis. So I think in the future, what would be great is just some dedicated training for those wanting to do chronic pelvic pain and endometriosis, and then also, just having a good test that's not so invasive.
I want to talk about imaging because people will say my transvaginal ultrasound was clear. My MRI was clear. And then, they operated and there was stage 4 endo. This was my experience. I had an MRI. So I had a pre-novo MRI, which is full body MRI. So full disclosure, they were like, we'll comp you the MRI if you post this online. So got it done. They're like, we see what looks like adenomyosis. We also see what looks like endometriosis, but we are not diagnostic. We cannot do that. You need a follow-up.
Yeah.
I go get a follow-up MRI. First I go see a doctor who tells me, this is why you should take your Advocate, everybody, because in the room he was telling me that adenomyosis is just a new trendy diagnosis. It doesn't have any bearing on fertility. There's nothing that can be done about endometriosis. My husband was in the room with me and he's like, I listen to you talk about gaslighting all the time. I just didn't think I would ever witness it. And he's like, and then you didn't say anything back. I was like, oh, because we already broke up. Like, he didn't know we were divorced. Papers were served. Like, it was already over the second he started that. There was no point in me wasting energy because I was like, see you never again. So I get an MRI and the radiologist is like, there's nothing there. It's totally clear. I get the MRI and I'm like, no, but like, I can see the adenomyosis in my own uterus and I don't read MRIs for a living.
Sure.
I'm like, read it again. He gets mad at me. He tells my primary care doctor that I'm just seeking attention basically and like, just trying to look for something that's not even there. I was like, oh, really? Let me serve this MRI up to a radiologist who actually reads endo. And lo and behold, get a whole Enzian score. They're like, yep, it is everywhere. So I tell this story because who reads your studies matters. Anyone can do a transvaginal ultrasound. Not anybody can see endometriosis on a transvaginal ultrasound. So talk to us about the utility of imaging. And then we're going to get deeper in like helping people navigate this.
Sure. So I always tell people the basic rule for imaging is just to tell me who I need to invite to your party at your endometriosis surgery. Okay. And it can be, I think in the future, imaging can be used vastly different, right? As we get better people to read them and better people doing the ultrasounds to look for endometriosis on an ultrasound. But for the vast majority of pelvic ultrasounds that get done, I tell people, if I tell you it's normal, I always write in there, that does not mean you do not have endometriosis. It just means probably you don't have an endometrioma based on our imaging that we're doing. So I'm saying we're looking for endometriosis, but we're probably not going to find it on the ultrasound. If I see an endometrioma, that already upstages you to stage 3, stage 4. I also say with the MRI, so I see this a lot, and it is 100% what comes down to who reads it, the radiologist or yourself. And again, another gap, gynecologists are not radiologists. Like, we're not trained to read our ultrasound. You have to seek that education outside of your already crazy busy life. So that can sometimes be a challenge. Again, another thing, MRI, if they don't see anything in your MRI, doesn't mean you don't have endometriosis. It just means maybe the colorectal surgeon does not need to be invited to your party. The urologist does not need to be invited to your party. I can probably go in and start and see what I can handle on my own. Certainly always want to have the availability of those other surgeons at your tip, but I don't need to plan in advance. Okay, so-and-so needs to be available on this day for colorectal surgery. So-and-so needs to be available on this day for urology. So it's really, for me, where I work, it's like, I just need to know who needs to come to your party. The other thing I can tell people is I can see basically an endometrioma and adenomyosis. Those are two other things that can be really, really big keys. And a lot of times they won't come right out and say it, but there's subtle signs for adenomyosis. So that also helps, I think, patients to understand that basically we're looking for these very specific things and it's used for surgical planning.
For people listening, adenomyosis and adenomyosis, they're the same condition we're talking about. In Mexico, everyone calls it adenomyosis. Also in Canada. And I was saying adenomyosis forever. There was a big debate I got into with people, and they convinced me to say adeno. But I want people who are listening just to know it's the same term, even though we said it a little bit differently. So why does it matter that we know who needs to be at the surgery first?
That's important so that the initial surgery that you have can be as complete as possible. So we want that first surgery in an ideal world to be a complete excision, which sometimes mean that our skills might be limited in what we can do, and you know what you can do. And so you might need a colorectal surgeon to be able to help you take down some adhesions from the colon or take down endometriosis from the surface. You might need a urologist to place stents. You might need to have them dissect out the ureter. It depends on your skill sets and what you know. But again, if you're looking at cutting out part of a ureter, you're going to want a urologist to be able to sew that back together. So it can grow in all these tricky places. And always the first rule is first do no harm. So that's kind of my guiding principle. But we want to try to get a complete wide excision on your first go.
And what happens if those people are not there? So let's say you go to someone, general gynecologist, who's like, oh, I can excise endo. They get in there. They're like, oh my God, it's all over your bowel. It's all over your bladder. Maybe it's like all over your diaphragm. We're finding it in all these places. What are they going to typically do?
That is variable. That is any number of things could be done in that scenario. Nothing could be done, which I also don't think again, we don't have a good non-invasive test available worldwide. So if someone goes in and says you have really bad endometriosis, that's still like an X-ray or an MRI. That's still a really good piece of information for you to leave and then be able to find someone, hey, here's my pictures. Can you help me get this disaster sorted out? So I still think that's a good way to at least know. I think the one thing that really I would hope was not done is ablation, but it is still done. The thing with that is if we're ablating these lesions is just burying them, and it makes them harder to cut out. That's probably the hardest thing is for gynecologists to understand that when you do burn it, just pick a few places to burn. Then when we go to cut it out, that inflammatory process has pushed those lesions deeper into the tissue, which makes it harder for them to get out, and you're at higher risk for complications. So you may end up with all these areas that are difficult to excise because of what was done.
Yeah.
And then what was the second part of your question? Sorry.
So just asking, let's say you've got you've got bowel nodules. You need a colorectal specialist there, but they're not there because your doctor didn't plan ahead. They didn't do the imaging. They didn't even know, because there's a lot who don't even know that you could do imaging. What are they typically going to do? To sew you back up and tell you, let's do this again?
So in those situations, and I've been in that situation myself early on in my career, where there isn't always a colorectal surgeon involved, or the colorectal surgeon comes in and said, this is going to be major for her. This is going to be probably a colostomy, probably temporary. But then I think that's something that somebody needs to know in advance. So if you have an excision, and yes, there's bowel nodules, I think the most important thing to do is take a lot of really close-up pictures. Same thing with the diaphragm. Sometimes I don't have a colorectal or cardiothoracic surgeon available. Okay, but I've taken an insane amount of photos. I know who to send you to. This person can talk to you about your procedure. So I do think that, yes, it's ideal to have everybody and you know exactly what's going to happen and you have the perfect excision, but that's just not life. It's just not. It's not the reality. I think you excise what you can, take a lot of good photos, and then you have those people at your disposal. Yes, you may need to have a bowel surgery. Yes, you may need to see a cardiothoracic surgeon. Yeah. So getting them in touch. But I also think that's not the worst thing, because do you really want to have this huge bowel surgery that you had no idea about and then have some big complication? You want to know. You want to be prepared for something. So I think that's the reality for a lot of people who are doing endometriosis excisions, is they might see stuff that's outside of their scope. The surgeon may not have access to the specialist they need that day, but you don't want them doing something crazy that they're not trained to do, or having, it's just a disaster for complications.
Do you feel like imaging, though, can make you better prepared and reduce the risk of maybe needing additional surgeries because you have the possibility of being able to see more, visualize more, and prepare the patient?
Yes, I think sometimes the preoperative MRI can definitely help with that. And that's really where I use it quite a lot. But it's wrong sometimes. It's just wrong.
Yeah.
And so you have to be prepared for that situation where it's wrong.
Well, and that's the other thing for people to know is that there's also the quality of the MRI machine
Right.
in the facility that you're at.
Critical.
And if you're rural and it's an old hospital, like we don't really know like if you're going to get a quality image. Then there's some people who will do gel MRIs and some who will not. I opted for a repeat gel MRI because I did have lesions on my bowels, and I was like, fill me up and let's make sure, because if I have to like have a resection of my colon, like I need to know that. I need to mentally prepare for that. And I need to have all the information possible going in. And thankfully it was just, we have to shave it off your bowels, which was horrific to recover from. So let me just say that like, just because they shave it off your bowels doesn't mean that it's a cakewalk, but it's certainly easier than a resection. And when you consider, women have jobs, they have families, they have obligations, like this is a lot to mentally prepare for.
Yes, it is a lot to mentally prepare for, which is why, if you get into a situation where you don't think you can handle it and the patients are planning to take, from a standard excision, maybe a week off of work. So for you to do something crazy like, shave off the bowel when she's not prepared for that, then it might mean another surgery. But you want the right people doing your excision. You don't want someone just, okay, well, I'm in here and I can take this off. You really want somebody who's qualified.
Yeah.
So.
Yeah. And that was part of my selecting my team, is that I asked the question. I think it's an important question to ask, is like, what happens if this is outside the pelvis? If this is, invasive in another organ, like what do we do? And their answer was, we bring in the best specialists. We try to predict that ahead of time and bring in the best specialists to make sure they handle it. And for people listening, you're always looking for that level of humility that I can't do everything. Here's what I'm really good at. But when it comes to the line, I find the person who can do it better.
Right. Yes. Having that humility to know what your limits are is huge. And it's okay to be like, this is outside of my scope. But again, coming back to first do no harm, right? The patient now has the information. And for the vast majority of patients that I see who ask that question, I'm like, I don't see anything that suggests we need a colorectal surgeon there. If there's a small lesion, yes, the colorectal surgeon can probably take that off from a surface level. But if it's going to involve a resection, I want you to have a full-on conversation with them. And again, most patients are fine with that because they've been trying to get the diagnosis for 10 years. So it's like, if they can at least find and get some relief and they can decide down the road, okay, yeah, I don't want to have these bowel lesions resected, then they can have a discussion and they can know what they're up against.
Yeah.
Yeah. As opposed to like their first endometriosis surgery being something they didn't plan for the recovery.
I talked with a neuropelviologist and endometriosis excision specialist, Dr. Nucello, and I will link to that episode. And he said, because we can't always see what is going on in there, I try to go basically worst case scenario with things of like, okay, let's say the endometrioma is this size, like, at that point, do I have your permission to make a clinical call, remove the ovary? How often is that kind of conversation happening, you think? I mean, obviously, it's happening with you, but, how often are patients getting that kind of informed consent?
I don't think that they are getting that informed consent at the times. For my patients, I do kind of walk them through worst case scenario mode and kind of see where they stand. And some people will say, I don't want you to take my ovary. Okay, I'll just take out what we can and we'll sew it back together. And there might be the tiniest piece of ovary left, but the ovaries are crazy. So it might be able to regrow and do its own thing. But I leave it up to you because, it's your body. You should have your own autonomy. I think that if you don't do a lot of endometriosis, you don't know what worst case scenario is. So then you can't counsel your patients on, this is the worst case scenario train. How do you want to get off of it if I get into this situation? And I do find it's different for everybody, especially that comes into a situation with like the fallopian tubes. Like, okay, your fallopian tube it's not functioning. It's not working. Would you want your fallopian tube removed? Because you're going to have one then. So everyone's a little bit different. Some people will. I just think you need to walk down that conversation with the patient. That's not happening a lot for people who don't do a lot of endometriosis, unfortunately.
Well, that brings up a really good point because you brought up ablation earlier. There are people who call themselves endometriosis experts, and yet they're still practicing ablation. And I actually, when I asked my audience for questions about endometriosis, what are your questions? There were still so many people asking, like, when should ablation be considered? My doctor's recommending ablation. And I'm like, why is ablation still a conversation? Like, this shouldn't be a conversation. So there are people who they think they're endometriosis experts, but they're offering ablation. They're not doing excision surgery. They don't do any imaging. They don't even do this informed consent. How can somebody wade through that? Like, what are like some of the boxes to check? Like, you were someone, you weren't taught endometriosis. You went and learned it on your own. What were the hoops that you feel like you went through that checked the boxes for you to be like, I now feel confident in my approach?
Sure. One basic question you can always ask, do you do ablation or do you excision? And if you're finding a mixed if you're finding an uncomfortable response to that question, then you're probably in the wrong place.
Okay.
That's probably the one box that you can check. I think for me, the boxes that I had to check to kind of get to that point were watching excisions, learning the excisions from the best in the country, watching a lot of videos, hearing them speak, hearing them talk, and also understanding, like, the big world that chronic pelvic pain is. It's a huge bucket of all kinds of things, and you have to understand a lot of how our system interplays, and so how different organ systems are affected by this. But you have to be interested. It has to come from the inside. I think that if you, and I don't know how to standardize the experts. I don't know how that will fix that problem. I think we face that in a lot of different areas of medicine. Like, you're an ADHD expert. Well, really, are you?
It's so true.
Well, you have, like, it's not just endometriosis. That's where sometimes I feel like we get kind of down these rabbit holes. I'm like, it's like this in all areas of medicine.
Mm-hmm.
Like, you have to. Now, I would never claim even myself to be an expert. Like, I do endometriosis. Here's how I do it. Like, I'm not saying I'm an expert. Like, but here's how I do it.
I'm going to call you an expert because when we put the average gyn and we put you next to them, your knowledge base, experience, and technical surgical skills are far above that. And I think that's what it takes to be an expert. And that when people are like, yes, I'm an expert and I'm continually learning, that's a real expert.
Yeah.
That is somebody who's like, okay, like, I know what I know, but I also know there's a whole lot we don't even know. And that is someone that I'm like, look for that person, especially if you bring them studies and they're like, I love this. I didn't know about this. I want to learn about this. Oh, that's a good doctor right there.
Yeah. Just that level of vulnerability and just humanity.
Mm-hmm.
I think there definitely just are people who train and they have this ego, and I don't know. I don't know if you'll ever be able to, like, tease that out of the people. You just have to. And I think that also comes from, like, being a patient yourself too, is understanding, like, who's in front of you, being the patient. They might not know everything, but if you can at least tease that out, like, okay, this person's admitting they don't know what the heck they're talking about, and they can get me to the next person.
Mm.
Yeah. So we need more doctors like that who are just like, this is where I have to say, like, I don't know, and here's what I would do.
What do you think in gynecology, like, breeds that ego and makes it where we don't have doctors who are more vulnerable, more humble about that? Because I have my theories, but I would like to hear yours.
I mean, residency, you're pushed to the limits in so many different ways, and you have to prove yourself. I mean, I think there's a lot of just, you got to prove you're the best. And then if you can prove you're the best, you're the best. It's not always like a happy, growth mindset type of environment. It's very, like, it can be very cutthroat, to be honest. I just don't think that was ever emphasized. Or I don't even think I ever saw a doctor in my training be like, admit to a patient they didn't know what they were doing, or admit that they may not have the knowledge. I think we're all kind of coming out, especially as young doctors. We not sure if we believe in ourselves. We're not sure if we can do it. And then we just, like, put on this facade, like, oh, I can do this. Like, I can. Yeah. So I think there's just not an acknowledgement of the vulnerability that goes into working with humans.
Yeah. So I agree with that piece. And I think that because it's women's health and women's medicine is kind of always seen as the lesser, that within medicine as a whole, right? There's like, I am like the orthopedic surgeon, and you're just a gynecologist who couldn't make it into a surgical residency. So that's why you're a gynecologist. And I think that also because the field is predominantly women, there is medical misogyny, which translates to patients and to providers. And I think there's a lot of women who are like, I have to put on the strong front. I have to be like, I have to fight for my place. And that is something that I think, again, it's not about the individual. It's so easy as patients to like get mad and hate the person in front of you, which is the doctor, and not actually understand what has gone into creating that person. And we've got a whole upstream issue. We've got ACOG who could care less about endometriosis. They're like, why care about endometriosis? We can make IVF like doctors so profitable. You don't have to say that. I will say that because I would love ACOG to prove me wrong. I'm really challenging them because it's what I ultimately want is them to care about endometriosis. But we see like the way that you just said residency, and so much of this paradigm is it works against the provider and it's the patient who ultimately gets harmed.
Oh, yeah. That's 100% what it is.
I want to talk about, we're going to go more into surgery because my audience has tons of surgical questions.
Okay.
However, there are people who can't yet afford surgery. They can't get surgery. Maybe they don't need surgery. Who should they be thinking about having as part of their care team, right? Because the surgeon is always one part. So I don't do surgery. When I work with someone who's endometriosis, I'm like, we got to find you a good surgeon. Whether you need them or not right now, we don't know. But we want them there already when we need them, not like, oh God, we have to scramble and find someone because we needed them yesterday. So surgeon, definitely a core part of the team. And we want to get their professional opinion. Who else should be on the team?
Good question. So the way that I think there's a few handful of clinics are set up is that it's a chronic pelvic pain clinic. And so for me, I'm managing all facets of chronic pelvic pain. It could be interstitial cystitis. It could be pelvic floor muscle dysfunction. It could be a vascular disorder. So, and I'm also a surgeon, but I don't think there's a lot of people out there that manage chronic pelvic pain and do endometriosis surgery. So I do feel like if you can find somebody who does all chronic pelvic pain and also does endometriosis surgery, that would be great. But if you can't, you want somebody who's does a lot of chronic pelvic pain that can do non-surgical management of pain. Then you have your endometriosis surgeon, for sure, a pelvic floor physical therapist. And then I also would argue somebody who has an interest in urological conditions, colorectal, and vascular disorders. But this is like a dream team. I mean, these are just not the realities that you have. But if you have somebody, you know, if you're in a small town or you're in an area that doesn't really have access to surgeons, then you just want somebody who has a good understanding of all the different things that can cause chronic pelvic pain and can hopefully try to get you to those subspecialists. But I think that's one of the bigger issues. And I've been approached on this. It's like, why don't you just start a chronic pelvic pain clinic and you could do endometriosis surgery and you can have a variety of nurse practitioners like doing the medical management. But I still like all facets of the chronic pelvic pain management because I do get a lot of people who are like, I don't want surgery. Like, I'm in school. I'm like going to school to be an attorney. I don't have time for this. So, you know, if they can get relief to the point where they can function and live their life, like that's great.
Well, and it's an important thing because as you said at the top of this, you were like, you got to talk me out of endometriosis because I see so much of it. And yet we can see things like women get, you know, IBS diagnosis, interstitial cystitis diagnosis, like they're getting all of these other diagnoses, which can ultimately be related to endo. Like these things can be connected. So I do think it's important to have that understanding. How do you feel about having like a dietitian or a nutritionist on the team?
That would be great.
You're like, oh my God, somebody make this happen.
But this isn't like, I feel like this is not the reality. At least in my world, it's not the reality of medicine. I mean, the chronic pelvic pain specialist has to be able to say, you know, here's where, yes, you can see a dietitian, you know, you can see an exercise physiologist, you can see all these people. So yes, having those people, but I don't think the average gynecologist, if they're even interested in endometriosis, has access or would be able to kind of connect people.
Yeah. Well, I think also there's people listening that they just know they're going to have to do this themselves. They're going to have to put together their own team. You know, before we started recording, I was talking to you about a psychologist that we're having dinner with tonight who helps a lot of chronic pelvic pain, especially endometriosis patients. That's another thing I think is missing. Anytime a woman has pain, we know depression, anxiety, suicidal ideation, like these things begin to skyrocket. Having mental health is so important. And just because you excise it doesn't mean the body doesn't remember, the nerve pain patterns aren't there, or that like somebody doesn't also have a grief of loss of organs and tissue or the years that, went by without help.
So the way I do my consults is kind of addressing all of those things, right? Looking at the endometriosis and components, but also looking at mental health and central sensitization. Are there urological things, GI issues? So I kind of systems base all of it and try to see what pieces also go with the endometriosis, because endometriosis does not travel alone. A lot of times it comes with a variety of different things. So you have to kind of not be so narrow focused and look at all the systems and how it's playing out for someone.
Yeah. When you talk about central sensitization, that's going to be new for some people. Can you explain that?
Sure. Central sensitization is the way I like to describe it is, somebody could be touching your hand and it just feels like in a normal functioning nerve that your touch is being perceived by your brain. But for people with central sensitization, an actual touch can feel like they're pinching that area with a sharp stabbing knife. So our nerves have remodeled. And now when we get any type of sensation to that area, to that nerve, it's sending out, oh my gosh, danger, danger, you're being pinched. Whereas someone might be trying to just touch your hand.
Yeah.
So those nerves have remodeled. And that happens over time in endometriosis and other pain conditions. But it's just important to be aware of that nerve remodeling and how, we may need to address that.
How does someone know that's happened and how would you address it?
So good question. There's some scoring that you can do. There's a few different types of scoring systems that you can do to determine a central sensitization component. But this can happen sometimes when you've had an excision, right? And you still have some of that residual pain. So like if the bowel, for example, is like moving in the area where you had an excision, you can still kind of feel that area and it may just be moving by whereas you're feeling the nerve is triggering that same endometriosis pain response. So, I think you only really tease that out over time and after you've had a chance to have an excision. That's kind of something that comes down the line.
And let's say you have an excision and this persists. Do you have therapies, ways that you can address that?
Sure. So I think the main thing with central sensitization for me, at least, is understanding what it is, anti-inflammatory responses that we can try, pelvic floor physical therapy, and sometimes neuromodulating medication can be really valuable. And that can be a little bit of trial and error. So, right, if somebody gets a good response with one of those neuromodulators for central sensitization, you're like, there's some component here.
Yeah. And I would assume this is a situation where keeping your journal, keeping your diary is really helpful.
Yes.
So if one of the questions that came up in my audience is that people are like, is surgery always necessary? Is it the only way to manage endometriosis?
No.
Okay. So what else can people be doing outside of surgery? We talked about pelvic floor physical therapy.
Yes. So pelvic floor physical therapy. And then I think that the number one thing you can do is find a progesterone that you don't have too many side effects on, and that could take some time, that will stop all the bleeding. So if you can't afford surgery, you don't have access to surgery, you don't have time for surgery, a lot of times doing pelvic floor physical therapy combined with a progesterone is enough. And a lot of people come to see me and they're like, I want surgery. I'm like, great. We have like a 6 month wait. So I'll put you on that. In the meantime, would you like to live your life? Yes. Okay. Let's do pelvic floor PT and let's put you on some progesterone that doesn't have too many side effects. And I will tell you, there's a fair number that come back for their preoperative visit and they're like, I'm fine and I got to do this. So
when you say progesterone, are you talking about progestin-based? Like
either one.
Okay.
We got to just find something that works for you. And a lot of times, for a large majority, we are using like norethindrone or medroxyprogesterone, and that will work for some. But I do find in endometriosis patients that they're more sensitive to the side effects of those medications. And so it can be tricky. So sometimes I'm going to the compounding pharmacy. I'm using more progestin-based therapies, or getting creative, but some way that stops the bleeding altogether with some concoction of that is the way to go.
Yeah. So firstly, I will link to the episode on progesterone intolerance for people because I talk about the difference between progesterone and progestin. Endometriosis patients, neurodivergent patients, women who have PMDD tend to be much more sensitive to progestins, have more adverse side effects, and be told, no, it couldn't be happening. There's no causation in the research that birth control could shift your mood. The other thing we see is there's a big crossover in all those conditions. So there was a really interesting study that neurodivergent women, specifically autism and ADHD, are more likely to be diagnosed with endometriosis. And if you have endometriosis, you're more likely to be diagnosed with these conditions. And that to me, I'm like, is very interesting, especially when you consider the high rate of PMDD these women are experiencing. So I appreciate you saying, like, we try to find what works for them, because sometimes, I mean, I'm someone, I try to gaslight myself that progestin will work. And then I'm just like this angry, crying mess, and it doesn't work. But because I have adenomyosis, I now have started taking progesterone during like the last 7 days of my cycle, just to be like, I just want a little buffer so that, and at this point, like my progesterone levels are still good. So for people listening, I tested them. Progesterone looks fine, but the indication is not based on my levels. It's based on, I don't really want that tissue to grow, and I would like to never have a hysterectomy. I like my body parts. I also don't like surgery. No offense, but
No,
I don't like surgery.
No offense taken. I think it's just you have to be really creative with your physician or your nurse practitioner. And that's the one thing that's hard to teach gynecologists. Like, you got to get real creative with people. Like, yes, it could be, I need birth control and I need a birth control pill, but that ain't going to be enough if somebody has endometriosis for a large majority. And so sometimes you're adding in like a bioidentical progesterone or progestin, something else on top of it. So the medical management of endometriosis requires an insane amount of creativity.
Yeah.
And so that's what I've learned, like just from other providers in my group, like, oh, you did this in combination with this progesterone, this worked well, she's not bleeding on this. So whatever it takes.
Well, I was going to ask you because at the top of this, you were saying these tissues respond differently to hormones. Can you talk about progesterone resistance that can happen with these tissues?
Yeah. So, I mean, over time, I think there are patients that I have that respond really well. Like they can get an IUD and they have a Mirena or another progesterone IUD and they respond well and they don't bleed and everyone's clapping. Like, it's great.
Yeah.
But
I love it when it's easy.
Yeah, that can be easy. But for a lot of women, that just is not enough, right?
Yeah.
So we've got to up our game. So if someone comes to see me, they have an IUD, they're still bleeding, I'm like, we have to add some progesterone to the mix because we need to get you to a point where you're not bleeding. So for some women who want to go the more birth control route, that's going to be a Mirena IUD and a Nexplanon, or 2 Nexplanons, or a Mirena and some progesterone, or a bioidentical progesterone and the birth control pill. So you can't just rely on one thing, which is definitely something that's not taught to gynecologists. And there's no research. There's none. There's absolutely zero about combining these different methods to find something that has the least amount of side effects where people aren't bleeding. And you're going outside the box, right? A lot of times when I'm on vacation, for example, then someone will say, oh, you were doing this? And I'm like, that's what we're doing. Is she okay? Yes, it's working. So you have to get creative. You have to be a little bold. You have to do things that other gynecologists aren't going to do, because it's often the case where there's just that progesterone resistance and the normal standard things are not going to work.
I love that you said there's not the research there, so we have to get creative, because we'll hear providers say you can't do that because there's no research to back this up. There's no research. And then, you'll also hear from the general public who are like, well, that's not FDA approved. I'm like, oh, girl, I can tell you how much stuff we do that's not FDA approved, like many medications we're using in women's health. But I think it's important that we do look at the individual. And I always, I've had people say like, oh, you're rebellious, and say different things like that, because I'm with you on that. Like, you have to get creative. But the way I always see it is that this individual has a finite amount of time on this planet, and I am not going to wait around for 2 decades for a research study to validate what they're saying is true about their body and what's working for them.
Yeah. For me, it was learning from someone else who was doing this and like reading through their notes and seeing those patients and be like, oh, she did this progesterone and this progesterone that made the patient stop bleeding and she got better.
Yeah.
Or she did 2 Nexplanons and the patient, so a lot of what I do is pretty creative with what I have available to me commercially and just finding different combinations. But I would tell you, there's, patients ask me like, well, I don't see any studies on like dual use as an Nexplanon. I'm like, there are none.
Yeah.
They don't exist. But, and then people come to us and they're like, oh, we should do the research. I'm like, I don't have time right now. I just don't have time.
It is so true. I hear that. So there's been so many practitioners on this podcast who are like, and people ask me to do the research. And I'm like, people will say that to me too. And I don't think people understand the time and the money it takes to do a study. And clinicians are great at participating in the research study, not so great at designing and orchestrating the whole thing, because it really takes somebody just dedicated to that. And it is something that I wish we could be doing more studies, but it's not that easy. And even if you do a study, if it's not double-blind, randomized control trial, people are like, that's not good enough. And you're like, we have to start somewhere, right? We have to start somewhere in building evidence and making a case sometimes to get the funding to actually do the research.
I mean, research is just not my forte. So if someone comes with a research project and like, okay, it's a really great idea. Let's take it to this person and see if they can help us. But yeah, it needs a whole team. I mean, in the private groups that I've worked with where they've done successful research studies, like they have a whole squad.
Yeah.
It's not like the clinician that's running that. There is like a whole squad of researchers and I don't have that available to me.
Yeah. What I haven't heard you say is Lupron.
Yeah, I mean, you can use Lupron. I mean, that's another thing in the toolbox that we can use. I don't use a lot of it because I really do find like if I do, norethindrone and prometrium or like the IUD and Provera, like combining things, I don't find myself having to do a lot of Lupron. The only time I'll do it, and I try not to do it before an excision because it can make the surgery just a little bit more challenging in terms of the scarring that it causes. Well, first of all, people hate Lupron, but second of all,
we hate Lupron.
They don't feel well.
So I'm like, oh,
they don't feel. And if somebody wants to do it, I'll do it. I'll do it with hormone replacement therapy at the same time.
Yeah.
But I usually use it in a situation where we're talking about like, stage 4 disease that we've excised as much as possible. The patient's still having a lot of pain. She doesn't want to have another surgery. She wants to try Lupron. Okay, sounds good.
But how long do you use it?
I mean, I'll use it up to 2 years if someone can make it that long, but
yeah,
I don't know. It's hard. It's a hard medication to take.
Yeah. So I've explained it to people, like everybody's like, oh, perimenopause is the worst. I'm like, try going. Just like within 2 weeks, you drop into the worst phase of perimenopause immediately, and it doesn't go away. Like it just gets worse. But you're doing add-back therapy.
Yeah, I'll do that.
With bioidentical hormones.
Yeah.
Yeah.
No one's in my experience, no one is tolerating Lupron without the bioidentical hormones. It's just not happening.
But there's providers not doing it. And
for sure.
I seriously, when I look at the brain research of the outcomes of like post-hysterectomy, a woman losing her hormones, going without those for years at a time, 30% reduction in her cognitive health compared to her cohort who didn't lose her hormones, I'm like, this is criminal. It has to be done with add-back. And I did Lupron and I did a tiny dose of like add-back of an estradiol patch. I'm in a place where I can prescribe for myself, and I did that. And that was just to take away the hot flashes because I was like, I cannot live like this. In retrospect, I'm like, my brain was struggling so hard. I should have done more. And then I did progesterone as well at night to be able to sleep and to also keep my sanity. But that also wasn't enough. Seriously, that's when I discovered like saffron is amazing for mood and so necessary. But it's a very, very hard medication. But some 20-somethings, they're being told like this is it, like this is the best, or we'll wait until it's really bad to have surgery. And as somebody who had surgery in their early 40s, I'm like, damn, I wish I had surgery in my 20s. That would have been so much easier to come back from.
Yeah, definitely. It's easier to come back when you're younger. Lupron is just a challenge. I find I can't get a lot of takers unless I do sometimes use it where we've done an excision. The patient has bowel lesions, diaphragmatic lesions. They're not in a place where they can have these big surgeries. They don't have access to those specialists. That's when I'll try Lupron. But
why does Lupron make the surgical outcomes worse?
The fibrosis that it develops in those lesions. So as it starts to kind of like kill it off, so to speak.
Yeah.
It just ends up creating this like scar, just very similar to like if you have surgery and you have a scar, it creates this scar that's just, it's difficult to dissect out. You can't get the normal planes that you would get, which is what you want to get to. You want to get to the normal planes in the anatomy to know that the endometriosis is gone. But when that fibrosis is there, you're like, where is the end? Where is the normal anatomy here? That makes it challenging.
When someone uses Lupron for 2 years and then has excision surgery, can there be worse outcomes? Can it be more difficult to recover from?
In my experience, it's harder to excise.
Okay.
And it puts you at a little bit, I think, of course, we don't have this data, I think it puts a little bit higher risk of complications, especially when it's like around your ureter. So that can make it more challenging to dissect the ureter out safely because of that scarring and fibrosis that happens from Lupron.
Yeah. And I wonder for the patients who are listening who are like, I had what I was told was complete excision surgery, but pain has persisted. And they would have a history of Lupron use. Could there be something related to that?
There could be. There definitely could be something related to that nerve remodeling. If you don't get good relief from an excision, that's kind of a basket of things that it could be. So it could be that it's not endometriosis, it's the whole picture, right? There could be a vascular disorder. There could be a bladder condition, a bowel condition. There could be a lot of other things that need to be looked at. So that is not, I wouldn't say Lupron, I would go to like my first thing, like, oh yeah, Lupron, that's definitely what it is.
Yeah.
I want to go back and be like, okay, wait, let's see tell me more about your pain right now so I can kind of see, is there something else here in your picture besides just endometriosis? Because a lot of times there is.
Yeah. Well, I think that's important for people to hear is that Lupron is one consideration, but I really appreciate, because I think that it's really easy for us to like kind of get like our experience, our bias, and just be like, I say this all the time with Lupron, so it's just Lupron. And it's like, you're saying it could be Lupron and I need to do my due diligence and ask more questions.
Yeah.
Yeah.
Definitely.
So what other kinds of things could be going on if somebody, so one person wrote me and they said, I had excision surgery and a hysterectomy 10 years ago, and I still get menstrual cramps.
That could be a couple of things. It would depend on if the ovaries are present or not, but that could be pelvic floor. I mean, the two biggest things that I see that get missed is underestimating how painful pelvic floor muscle dysfunction is. And number two is vascular disorders. I think there's a wide, if endometriosis is largely unrecognized, but pelvic venous disorders are even a bigger basket that are unrecognized. So in that situation, I'm usually having someone see an interventional radiologist who can do a good job evaluating for pelvic congestion and seeing if there's a role there. And then also making sure people are doing pelvic floor PT with a good PT. So I have like a couple of places where I'll send you, and then there's a few places where I'm like, you got to have pelvic floor PTs that are very versed in endometriosis and pelvic floor.
Yeah, I agree with the endometriosis component. And after my excision surgery, I've been doing pelvic PT for like 9 months now. But then I had to have knee surgery. So that's off the table. I was like, I need a 3-month break from that while I do PT for my knee. But the trigger points that I didn't even know I had. And I will say that I feel like, because I was seeing her before the excision surgery, but after the excision surgery, it's like the layers of the onion started to come off. And now the lesions were removed, we were able to get deeper. And I'm just like, I was making a joke to her because I had this really painful, like causing my legs to bounce trigger point. And I was like, I'm pretty sure that's like when I fell in the monkey bars, or, the stairs when people on YouTube can see me straddle and fell when I was like 9. Like, and I'm pretty sure it's like way back then. Like, that's how like deep this feels, is that it's like it's been with you for decades right now. So I think it is really important to consider the pelvic floor physical therapy piece. What is pelvic congestion syndrome for people listening who don't know?
So pelvic congestion syndrome is going to be, there's a number of different diagnoses that fall under that bucket, but it's basically the veins in your pelvis are not returning blood to your heart like they should. And so blood is pooling in different areas, and that can cause pain. And so I think there's a lot of pelvic pain that's caused by pelvic congestion syndrome that we haven't really acknowledged. And I think as somebody who trained, as a gynecologist, what we're taught is that pelvic congestion syndrome is very commonly seen on imaging, but it's not clinically significant. And I don't think that is correct.
Okay.
I think that that's what we're taught. But I think the more we see some of these newer therapies coming out from interventional radiologists like iliac vein stenting and some other venous therapies and people getting relief, I think we need to pay attention because I think that that's even a larger area that hasn't been acknowledged.
What are the symptoms of pelvic congestion syndrome?
They can be all the same symptoms of endometriosis.
Fun.
That's the problem.
Yeah.
So that's where I say, like, if you get some relief with your excision and you don't get complete, okay, have we really looked at the pelvic floor and is there a vascular cause as well?
Mm-hmm.
And I think one of the things, it can be pain outside of your cycles, it can be heaviness or pressure, but a lot of times it is a very similar overlap of symptoms.
Mm-hmm.
So while I think endometriosis is like this thing that's getting up and moving, I think we also have to acknowledge that there's other things that can cause your pain.
Mm-hmm.
So if you get an excision, you're not better. You got to have somebody who can dig deeper.
Yeah.
And the two most common things that I see contributing to pain are going to be the pelvic floor and the vascular disorders and pelvic congestion.
What if someone's seeing varicose veins, spider veins in their legs? Could that point that we've got pelvic congestion issues?
Mm-hmm. Same thing with swelling. A lot of POTS patients. So people have POTS symptoms or even just orthostatic tachycardia syndrome, which is where your heart rate races when you go to stand up. So I think that can also be a big sign. Like when I see someone who's had an excision, a good excision, and they have POTS and their legs are swollen, varicosities, I'm like, we have to get you to see a vascular interventional radiologist.
POTS, ADHD, autism, PMDD, endometriosis all also go together. So as you bring this up, I'm just like, you guys in the comments, you can, if you're popping off light bulb moments, I want you to definitely let us know because I think you just connected a lot for a lot of people. And I think POTS gets ignored a lot or it gets relegated to this is just a cardiovascular issue. You need to see the cardiologist without considering that like the nervous system's involved. And now you're like, your entire pelvis vascular system could be involved as well.
Yeah, I mean, this is only something I've just started learning about from experts in the area. And I saw one speak at a conference who happened to live like down the street from me. So I spent a couple days like working with her.
You're like, coffee. I'll make coffee every day. Teach me about POTS.
It's shocking though. Yeah. Like just spending a very short period of time with this group, learning how many pelvic pain patients they see who've had good excisions, who still have pain. And then it really ends up being some type of constriction in their pelvic vessels, and they get better with stenting and other types of therapy. So I think we're going to learn more about that in the future. They're doing some studies. Some other people are doing some studies that are going to be coming out, but it's largely been taught to the gynecologist that pelvic congestion syndrome may be seen on imaging and it doesn't have any symptoms, but I think that it actually probably does.
Yeah. Stenting. You've said it twice. People don't know what that is. Break it down.
So a stent is basically like a long kind of tubular structure that you can put in a vein. Like if you have nutcracker syndrome or May Thurner, these are different vascular or venous issues that can open up the vein and keep it open instead of having the vein constricted. So it opens the vein, it keeps it open. Blood flow can get through the pelvis, back to your heart, back to your brain. So you don't feel like, you have POTS symptoms or a lot of the pelvic pain can go away once we've relieved that constriction in the vein and opened it up.
Why is there constriction in the vein? Like what is going on there?
So sometimes it can be from anatomical variations. Mm-hmm. They're more common than you would think. And other times it can be from endometriosis and from scarring and from adhesions.
Yeah.
So those are kind of
interesting. So what are you doing? So someone's having an endometriosis workup. What are you doing to check for pelvic congestion syndrome, which everybody listening will acknowledge as a big bucket, right? Is a bucket. And there's lots of other things that can be diagnosed specifically within that bucket. But you see someone with endo and maybe they tip you off. They say, I have POTS as well. What do you do to work that up? Are you doing imaging?
So in that situation, it's really important to listen to the patient. Like, what is the quality of the pain? Is there a heaviness? Especially if anybody describes a heaviness to their pain, I'm like, with the combination of POTS, especially if I see some lower extremity swelling, I'm like, do you want to do your excision first or do you want to see an interventional radiologist first to see if there's a way we can treat that? And it's, everyone's a little bit different. Some patients have just like the classic pain during their periods. But if anyone's having pain during their periods and outside of their periods, the two biggest things I'm thinking are pelvic floor and a venous congestion. So pain outside the period and a heaviness are two of the biggest things. Mm-hmm. And then POTS, that would be another big one where I'm like, we really got to have you see someone. And the problem with these venous disorders is that the protocol in the MRI has to be correct. and that a lot of times the radiologist isn't even looking for it and they just completely miss it. So while you might have an MRI that said it's totally normal, it could be wrong. It really has to be looked at by somebody who does a lot of vascular pelvic pain.
So we talked about you need a radiologist who actually gets endometriosis, who's been trained in it, can look for that. Pelvic congestion syndrome, you need a radiologist that specializes in that. I think that's so important for women to hear, because just like women are told your blood work is normal, but you have all these symptoms, you also might be told, oh yeah, well, your imaging is normal, and it's not. You have to have that expert read it.
Yeah.
How do people find that expert though? Because that's the thing. I mean, people ask me and I'm like, well, I know a lot of people. Like I know a lot of people. I called my friends. I was like, who's the radiologist I need to send this to? But I'm like, how does the average person, because the way it flows in the United States is that when you order it, it goes to the radiologist. We can actually say, I want to get it over to this radiologist. But if your doctor doesn't know who to get it to, what can a patient do? You're like, I have no answer.
I don't have an answer. This is like a hot topic for me mentally that I'm trying to kind of uncover. There's a couple people in the United States that I know are doing this work and are doing it right. And so I just have to send it to them to have them take a look.
Can you name drop them?
Oh, sure. Yeah. So Brooke Spencer and her team at the Minimally Invasive Procedure Center in Highlands Ranch, Colorado. And then Dr. Hutchins, which I can't remember where she's located, but she is online. She's also doing a lot of this work as well. And so I just don't think there's a lot of intervention radiologists that are interested in the pelvic pain patient and helping them, right? And from what I understand from these people who are doing these procedures, like the iliac vein stenting, is even if you get to the point where they're like, yeah, you need an iliac vein stent that can help with your pelvic pain, they're not placing the stents always correctly. So this is like a bucket of, I don't even know what to do at this point. For my patients, I send them to this group. I say they look at the imaging, they determine what the issue is, and they put in the stent. And that's why, if you saw my post recently, like I took an entire day off to go learn from these people, because I felt like it was that important, like as important as endometriosis, to find out what they're doing, how they're doing it, and how it can help people.
Does pregnancy put you at risk for pelvis?
Yes.
Okay. I didn't even get the question out.
Yeah, pregnancy can put you at risk for pelvic congestion, but I have seen a few patients actually who have not been pregnant and who've had it.
Yeah.
And sometimes your doctor can see it. I've been looking more and more for it when I do my scopes, when I do my excisions. I've been looking more and more for it, and you can tell like the vessels are just really dilated and tortuous and kind of twist and turn, kind of like a varicose vein in your pelvis. If I see any of that and the patient has symptoms after her excision, I'm like, I got to get you over to these people.
Yeah. For
them to take a look at an MRI and then determine if you're a candidate for a stent.
Yeah. Is there anything that patients can be doing outside of surgical intervention for this?
No, because it's like a constriction. I mean, there probably is. I don't know. But we're talking about a very narrow, a couple millimeters where a vein is supposed to be, wide open and patent. Like, I don't know how to correct this to this without a surgery or a stent. Yeah. So it's like, I don't...
Yeah, I wonder, like, I often wonder if, like, there's something going on with the nervous system of, like, what about potentially, like, nutritionally, we know, like, bioflavonoids, vitamin C is, like, really good for veins. But, as I spout all this off, I'm like, other than something that vasodilates you, right? Like, I mean, I'm not an expert in pelvic congestion syndrome. So, one question I have is that, like, are there medications for vasodilators that might be helpful?
I think it just has to be. And this would be a great person actually to have on your podcast.
Yeah, okay.
Either Dr. Hutchins or Dr. Spencer, and they can talk more about it and talk more eloquently about it than I am. But I can't. I also was thinking that same question. I was like, is there any way I can help these people without opening up the vessel? And I
mean, other than temporary, put your legs up the wall every night, right? And
but like for some of them, it's just an anatomical thing that has to be corrected.
Yeah.
So
it's a difficult place to be in. And it's also something that, like, I bring on surgeons on the podcast and we talk about surgery, and then we often try to talk about things outside of surgery as well. But sometimes surgery is just, the only answer. It's like what I just went through with my knee. I'm like, no, can we do anything else?
Right.
And they're like, no, there's literally tissue lodged in your knee joint. You got to get it out. I'm like, great. Okay.
Right. It's the same thing like with the endometriosis, right?
Yeah.
You can try medical things, but if you're not getting better, like I can't remove them. there's no medicine to remove them.
Yeah.
So
one question that came up as you bring it back to endometriosis, somebody asked, okay, so can endometriosis stay minimal your whole life, or is it always going to grow? Is it always going to keep, being problematic? Is it something that like I have to worry about it moving into my organs?
I just think I've seen such wide variety. I would say yes, sometimes it can just stay very minimal.
Mm-hmm.
And it kind of depends. That's hard to say because sometimes then they end up going on birth control, right? For contraception, just straight contraception, they need birth control. So like, did it stay minimal because that person was on contraception? But then there's some people who have endometriosis very early on where, even them being on contraception, it doesn't matter.
Yeah.
It just spreads like wildfire. So I don't know. Yeah, for some people, you just stay kind of this like a minimal stage 1, 2 anti-inflammatory, but I don't think that's true. I don't think there's like an overarching statement. Usually once I see the endometriosis, I can kind of say, okay, once you've excised it, like, I don't think this is going to grow back because it's more like surface level. But that deep infiltrating stuff, I'm like,
yeah. Well, I think it's also important, as I frame this question, is I never want women, firstly, you never caused your endometriosis. And secondly, nothing you did personally, like, was like the deal breaker of like making your endometriosis like the worst thing ever. And there's a lot, I think, especially now, it's become very political about like this personal responsibility in healthcare. And yet what gets left out of that conversation is the environmental impacts that you do not have control over. So when you've got forever chemicals coming through in your water, like you might clean up all your makeup to have it as, endocrine disrupting free as possible, but maybe your water supply, maybe you live near farmland. Like there's all of these variables within the environment that also can influence your health and the development of chronic disease. And so, I think it's important, and I always want to empower people to take as much control as they can over their life. I think it's also important that we recognize that you can live your absolute best life and try your best. And sometimes life just hands you variables that you didn't see coming and you could have never controlled.
yeah. And that's a hard conversation to have with patients, I think.
Yeah.
Just understanding that some of this is out of your control.
Oh, totally. I want to control everything.
Yeah, and they do too. I mean, right? Like they do too because it feels like something you can control. But, it's the same thing. Like my son has ADHD and like I feel like my husband and I will constantly go back and forth. Like, we can control this. Like, we can fix this. Like, we'll get him in the right sports. We'll put him on the right meds, like right therapies. But like sometimes we're just like, this is outside of our control.
Yeah.
Like and I feel that same way with endometriosis. Like, I'm like, you can do all these things and it can still be an issue. So please don't, keep searching for like the perfect supplement or, the perfect exercise routine. Like some of it's just out of your control.
Yeah. And there's, I think it's really hard when a patient's like, I haven't touched sugar in like 10 years and I like, don't stay up late. And they look back and they're like, I did everything perfectly and I didn't get to live my life. And yet this still happened. And I think that's hard. And sometimes we have to recognize that like there is an experience in this life to have as well. And within wellness culture, I think that perfectionism is something that becomes this gold standard. And I'm integrative. I'm always like, I want everything. I want every single tool at our disposal because whatever you need is what we want to use. I'm a buffet. Like I don't eat at buffets because of foodborne illness. But when it comes to medicine, I'm like, give me the buffet and let's pick and choose what we want to put on your plate and what your plate can actually handle. And I think, sometimes we have to just look at things and say, like, you may be thinking, wow, I ended up in surgery anyways, but what you're not actually seeing is that how much worse would this surgery have been? How much harder would the recovery time been? Like, you don't realize that, like, everything that you put in was positive towards the outcome here. And that, like, not all of us are going to avoid a medication or avoid a surgery our entire life, but living that life to the best of your ability is going to influence those outcomes. I mean, you're going to reduce medication side effects in some instances.
Right. I think that it's important to go through that, like, discovering what works well in your wellness journey and also pairing that with what we have available to us, like surgically and medically. It's not a either or.
Yeah.
And I think I've had these conversations where women will say, like, I'm doing all of this stuff. Like, do you think I can still avoid an excision? I'm like, we can try. Like, we can try to keep you out of the OR. Like, whatever you want to do. But just sometimes it involves all the things. So, you can't always outsmart your endometriosis if it's there. You sometimes have to use the tools available.
That is such a good soundbite right there. You can't always outsmart your endometriosis. I'm like, yeah, I think we all need to hear that. You did talk about reoccurrence. How can somebody reduce their risk of recurring after excision?
Yeah. So during the excision, it's important to get, like I was saying, to those normal planes in the anatomy where the clear spaces are. So if we can get those wide margins, we know anatomically and things are back together. What I do in my practice is I say, like, there's no bleeding after excision. None. How you want to do this is entirely up to you. Here's the 500 things that you could do in combination, but there needs to be no bleeding whatsoever. And I find that those patients have less recurrences in my practice. I don't know that that's true for everyone, but like some of the combinations that I use, like, they're not studied.
So you're saying no cycling?
None.
Okay.
But I still have found that in really deep infiltrating endometriosis that I can't. Nothing that I can do medically. It's just like, we don't have this medicine does not exist on this planet yet. So there are some cases where no matter what, even if I don't cycle people and I go back in there and they have a recurrence, I'm like, it is what it is.
Yeah.
At this point in 2025, here's where we're at.
Yeah. Well, I want to ask you, though, because there's women who get excision surgery with the goal of getting pregnant.
Yes.
So then
I don't put them on anything.
Okay.
Yeah. Yeah. So that would be the exception is, right? We're trying to get pregnant. Okay. We want to try to get pregnant in those first 6 months immediately following your excision. Like, we need to be ready to go. Infertility evaluation needs to be complete. We need to have normal semen analysis. Everything needs to be in order because right after that excision, we have about 6 months. So for those gals, no.
Why is it 6 months?
I think after about 6 months is when they see those lesions kind of start to regrow and more inflammation starts to build to the point where it can interfere with pregnancy.
Yeah.
And there was that study that came out recently, and I can't think exactly what it is, but it basically showed after like 6 months, you should get them in the hands of an infertility specialist. But also, like, I always tell patients, like, do you want to do this for another 6 months? I mean, it's up to you. You can keep going, but the chances are less and less.
Yeah.
As you get between 6 and 12 months. So.
Yeah. I mean, that's hard to hear, but I think it's also important to hear. And I've had other fertility specialists on the podcast that are like, we try within 3 to 6 months for her to get pregnant, like post-excision surgery. And then I know it also differs if like the uterus was involved at all. And like if you had to shave anything off the uterus, or maybe there was, a focal adenomyosis and you had to remove that piece. So it starts to get really tricky, which is why I think it's really important to highlight what you said, which is that getting that fertility consult and making sure you have that player on the team. So we talked about the team already, but if you're wanting to get pregnant, that brings in a new team player.
And I think that there's obviously some people who do all of it, and those people are even smarter than I am. But yes, you want to have everything. And sometimes that means having an egg retrieval before you have your endometriosis surgery. And sometimes it means after. So working with them to try to make the goal what it is.
Yeah.
But excision alone can increase chances of conception by up to 40%. So if you want to try that, I think it's worth a 6-month trial. But after that, we need to loop in the infertility specialist.
Yeah, no. And for people listening, it also depends on your age as well of all of these considerations. And it was something that when I was faced with, my endometriosis surgeon was like, okay, we can give you a little algorithm of what your AMH is. And if your AMH is less than 1, you need to do an egg retrieval before you have excision surgery. And my AMH ended up being like over 2. And I was like, lies. No, like rerun that. And then it was over 2 again. And I was like, okay, at like 40 something years old, this is okay, like I'll take it. Yay. However, I opted to do the retrieval first because I knew it was going to blow up my lesions. I knew that it was going to be provocative, right? And it did. I mean, sure enough, they were like, yes. And we saw lots more. And I'm like, yeah, because all of that estrogen stimulation. So I ended up just going that route just for that reason, that I was like, every little bugger that exists, I want you to see it. And of course, so people listen, you have to wait a period of time because you get very inflamed during an egg retrieval, and you have to wait a period of time for the inflammation to go down. But it showed me that, that was really a definitive for me, where I'm like, everyone with endometriosis needs to understand IVF makes endometriosis worse, because it absolutely does. We do not talk about it. And I was managing my endometriosis naturally really well, living pain-free, third egg retrieval, thought I was dying. Like 3 weeks later, I was like, I think I'm dying. Like something is so wrong in here. And I didn't know I had endo yet. And then I had a fatty endometrioma. I'm like, that makes so much sense now.
Yeah. That's hard. I really find that to be a challenging place for women who have to go through egg retrievals. I think it really is like, you really got to look at your life and be like, what am I going to be able to tolerate
Yeah.
in this period of time?
I think we have to be honest with endometriosis patients. I think there's too many reproductive endocrinologists who aren't looking for endometriosis. And when things get really bad, I mean, I woke up from my egg retrieval crying, and they were like, we need to get you more meds. And I was like, there was that nurse at Yale who was like smuggling all the fentanyl. And I was like, did someone steal the pain meds? Because I'm feeling everything. They immediately were like, we have to do transvaginal ultrasound, like something's wrong. And they were like, your entire cavity is just inflamed. And I'm like, yeah. And nobody ever thought to say endometriosis to me. So I share this story with everybody because if I had to go through it, then it's a great teachable moment that hopefully I can prevent someone else from going through it. But I want to ask about endometriomas as I brought it up. So a big question is ovary removal ever necessary, or should the goal always be to preserve them?
I think it depends on you. Depends on what your goals are. If we're looking to do an aggressive excision and surgery and you're young, yes, let's try to keep those ovaries.
Let's quantify young. Okay. So what are we talking about here? If you're under 45, let's try to keep them. If you're over 45, and what size of endometrioma we might want to remove them?
I mean, I always try to go in to say, like, let's try to keep the ovary.
Okay. I like this.
Okay. Yeah. So let's try to keep the ovary. Like, let's just try and see what happens. Sometimes, and it's not a lot, but sometimes it is more challenging to get to those normal planes when you're doing like an endometriosis surgery on the ovary. So sometimes it is challenging to get to that restoration, that normal planes to like get you as much wide excision as possible.
Yeah.
And I just kind of go in with, we can probably, there's very few situations where I feel like the ovaries need to go unless you want them to go. Like there's definitely people who are like, it all must go.
Yeah.
That's the end. Okay.
I like that you give women the choice.
Yeah.
Because some doctors,
I'm not your mom. Like you decide.
Okay.
What do you want to do? If you want me to save that ovary and there's this like 2 millimeters of it left, fine.
Is there a certain age though where you're like, let me ask, is there a certain size of an endometrioma that makes you think, I probably can't preserve this ovary? Let's start there.
I don't have a cutoff.
Okay. You just try no matter what.
Let's just try.
Okay. I like it.
And if it's,
I'm a fan. Yeah.
I don't have a certain size. I guess if it's like 20 centimeters or something and there's zero, you can find no anatomical ovarian cortex, then maybe.
Okay.
But I don't have a cutoff.
And do you have an age where you're like, at this age, it's probably okay if we take an ovary, like when you're consulting someone?
I leave it up to them.
Oh, okay.
I would say probably over 50. I don't know that, that would kind of be, there's some evidence to kind of say over 50, if you're going to be doing that surgery, do you really want to keep the whole ovary? But if you want to, it's fine.
Mm-hmm.
I give you the choice. Yes, I want to keep it over. Okay, we'll do everything we can to try to save it.
Yeah.
It may end up like a tiny remnant, but probably under 50 is kind of where they say ovary removal. It might just be easier to do it that way.
Mm-hmm. And for people listening, the average age of menopause is 51. So your ovaries have already stopped at that point. And for some people, you might be in perimenopause at 45 and it's like, well, you're going on HRT anyways. And, this ovary might not be the healthiest.
Yeah. It's just an individual conversation. Do you want it removed? Do you not want it removed? How do you want this to go? And
does the concern for, like having ovarian cancer ever come into play?
I tell them if they have family history of ovarian cancer, I would just take it out if it's me.
Mm-hmm.
But a lot of times I find what patients say is, if you think I'm going to be out of pain and it's not worth saving, then go ahead and take it. If it's so intertwined, then I would rather get to the normal tissue planes than kind of keep it. So it's individual. And I haven't found a real like strict cutoff for people. I just kind of give them the choice.
Okay. And then when it comes to hysterectomy, this is something that there are still doctors, I'm going to pull a book out of the Southern Playbook of bless them, that say hysterectomy can cure endometriosis. Can we please talk about that?
Yeah. That's said a lot. I think that it can help quite a bit if you have adenomyosis, which, tends to run with endometriosis. And so I think it can help, but if you don't do it with an excision, I just don't see how we're anything's making sense there.
Yeah.
I think that comes from a place of, again, people not knowing what to do. Like, I don't know how to help this patient, but I can do a hysterectomy. And maybe that'll help a little bit. It might help with the adenomyosis, but I think, again, that comes from that line of thinking I've never heard taught in training ever.
Wait, so you were never taught that a hysterectomy cures endo, but yet we've got like a little like cage of parrots on the internet who are just spouting that over and over and over.
I think it's because people don't know what to do.
Okay. Which, to their credit, what you are saying, and I think this is important to dissect out here, is that you're saying they are just trying to help. They're trying to help and they think this might help. But why is it that a hysterectomy without excision is not going to help?
So the endometriosis still lives. The actual disease is still living in the peritoneum or that space all around the pelvis. So you've not removed any of it at all. So, it's kind of like leaving a big mass behind. You've left the big mass behind, but you've taken out the uterus. It's not going to help.
Yeah.
But this is not stuff that I'm telling you is taught in training. Like this idea. And again, I think where I've seen patients come to me where they've had a hysterectomy, they had ovaries removed, because you have an endometriosis excision. I honestly think the gynecologist was not trying to be a jerk. I think that they legit did not know how to help this person. And there are some people that get better who have chronic pelvic pain who have a hysterectomy. But I have seen a lot of people with all of it removed and they're like, I'm still in pain.
Yeah. Oh, and there's also been celebrities who have touted like having endometriosis. And so I just decided to get my uterus removed. And it's like this hysterectomy is like this women's rights thing that like starts to come up. And then I think it's like when Angelina Jolie had her like double mastectomy. And then suddenly I had patients who were like, should I get a double mastectomy? I'm like, why are you listening to Angelina Jolie about like medical advice? And I think we saw that I think it was like the last 7 years, several celebrities just talking about like, I had endometriosis, so I just got a hysterectomy. And I'm like, slow that down. Like that was part of like a bigger conversation. I'm hoping there was excision surgery in there, but like that only perpetuates this myth that like, just remove the baby container and like, you're going to be fine. And what we've heard so far in this conversation is that like, it doesn't only have to be endo. Like it can be so much more. And the hysterectomy isn't just the one-stop shop for women.
Yeah. The thing about it is in the past, I think maybe a generation, the older generation where that's what's happened. Like my mom had a hysterectomy, my aunt had a hysterectomy, my grandma everybody had a hysterectomy. Okay. It was just like what was done. Like they're just like, gut it all, take it all out. And I still actually find people coming to me being like, just take it all out. I just want everything gone. I'm like, okay, I'm not going to just take everything out. We can take everything out. And here's what else I'm removing. Okay, but are you taking out the uterus? I'll take it out. Like, so I think that we're like kind of seeing some generational stuff come down there because that's what was done. Like if you had anything going on down here, it was like, just take it out.
Yeah. What's interesting is you say that what comes up for me is that like generationally, that was, are you done with children? Okay, just hysterectomy, take it all out. Our generation, because I'm assuming we're around the same age, was like, did you start menstruating? Just take the pill. Like, just take the pill. And so much of women's medicine is like, your lady parts, right, are the problem and not what might be going on?
Yeah.
I look back at this and I'm like, when I had horrific periods that made me vomit. I missed school. Like I bled with a heating pad on the ground for like 7 days out of every single month. Like that was so clearly endometriosis, like so clearly. But like doctor after doctor, all I was told is just take the pill. The pill solves everything. The pill is like your best thing. And it didn't help. And I just went through like a decade of depression and pain of taking the pill. So I think like it really kind of comes on that bigger conversation of like, why do we just have one intervention and we call it good enough women? You should just be thankful and apply it to everybody.
I don't know.
Oh, come on. You don't have an answer. Come on. I know this keeps you up at night.
I don't know. I mean, I think it was like the people who just taking everything out with their hysterectomies, like that's because the pill wasn't available. And then the pill came on the scene, and then it was like, ooh, you can like maybe not get pregnant if you don't want to get pregnant.
Yes, we like that part of the pill.
Right? Like, ooh, you know what I mean? So then as many people weren't having to just take everything out. So it just kind of has shifted. And now we're seeing like more and more people who have been on the pill in the situation and they don't want to be on it anymore. And they find out, oh my gosh, this is my reality without it. So, I think that'll shift. I don't know. I don't know the answer to that one.
Well, I think we're also seeing doctors like you just like stepped on the scene on social media and you like ended up in my feed and I was like, this person's fantastic. You're like, I'm going to say this. I don't want this to be rude, but you are hilarious. You're far more hilarious in your videos than in an interview. And I know this is a more high pressure situation. So I want everybody to go watch your videos. And I think they're going to be like, wait a minute, is this the same person? Yeah, you're always like dancing or rocking out, or you got your daughter with you.
Yes.
And I'm just like, you're just such an awesome duo. But I think we're seeing more doctors. It's something that like, I want to pose this to you because I have said to my husband, the problem is not, when we think of medical misinformation, the problem is not the rise of influencers. It's not the reach of influencers. It's not influencers at all. It is doctors who have neglected women, who have created this gap, and who have forced patients to go outside of the medical community to look for advice. And the biggest thing that doctors can do is not, I think, calling out misinformation of like, this person's so stupid, is a really bad negative content, and it only reinforces in the people's minds who think doctors are the enemy, that they are combative and the enemy. But I think doctors coming online, educating more, being human is going to be the most powerful thing to rebuild trust, but also make it to where patients are like, I want to go back into the medical community. I want to go back to them for advice. What do you think?
Yeah, I mean, that was one of the reasons I decided to do it, because I debated it for a while and my patients would just come to me with the TikToks like, look at this TikTok. And I'm like, and I felt like I could do it better and more funny. And yes, I'm probably not as funny in person, but
I'm also not. People will always be like, you're so funny. Can you like say a joke when I'm speaking on stage? I'm like, no, I cannot.
No, I
absolutely cannot, because there's an expectation.
Yes. So yeah, I'm probably more funny online. But I think that was one of the things that there was just so much negativity about doctors in the endometriosis space. I was like,
yeah.
And then I was like, I'm not doing this. I'm like, I am going to get eaten alive on Instagram and TikTok. I am going to just get eaten alive if I say things in a certain way. And part of that came from like, you have to be really careful with your language too, especially in this community. I found that, sometimes the way I want to say something like in life, right? Like if I just say it like this, it's not going to land well. So there's a little bit of finesse learning there. But that was one of the reasons I was trying to do it, is like, listen, we're all not the enemy. Like, I actually do want to help people. Like, sure, I could have just stayed a gynecologist and like done all the like boring, stuff. I didn't have to do any of this. It takes away from my time, my family, like all the things. But there are some of us who like actually do want to help. And I try to bring a little bit of humor to the space because I just feel like it can be sometimes very dark.
Yeah.
And yeah, I hope that message gets out there, that we're all not like that, that there are people who care. There's people who are interested in this. So,
yeah. Well, I think it's important. I think the work that you're doing is really important. I made a joke the other day on social media because I explained like, hey, there's one theory of endometriosis where these stem cells that would have become our reproductive tract migrated during, embryonic development. And like, I go through all of that and I made this joke. I'm like, there's a playbook of, I don't know if it's like set up, maybe somebody is like really smart with AI and just has it reflexively to comment, but you say something and it edges towards like endometriosis could be derived from endometrial tissue, right? And people are like, endometriosis is not the endometrial tissue. And I'm like, yeah, bro, that's what I said. Like, and I was talking, and they're like, you said that it could have been. I'm like, okay, I know that embryonic development is kind of complicated. We don't all get taught it. And even in just like saying that, of like trying to acknowledge it, like, I get that. They're like, what are you calling me dumb? I do understand this. And I'm like, I'm not saying that. Like, I'm just saying that like, maybe I could have done a better job and this is complex and confusing. And like, and they're like, oh, so you think it's too complex for me to understand? And I'm like, oh, you woke up and chose to hate someone today, and I'm not someone. I gotta just,
I love that.
I gotta just walk out of this conversation. And I think that's like what makes working with the endometriosis community and trying to support them so hard is, there's one person who comes in and decides that like this pent up rage and anger, like they're going to offload it on you. And it can be really easy to like let that bog you down. And I always have to just go back and look at the comments. And like, I just had someone last night that she was asking me a question about like a hysterectomy. I was like, here's this podcast episode. And she's like, you've helped me through every stage of my life. She's like, you helped me when I was having period problems. You helped me when I wanted to get pregnant. You helped me postpartum. And she just went through, she's like, and I've never even met you. I've just seen you online. And I'm like, I'm going to hold on to that forever. And I'm going to put this up of like a total stranger on the internet has had every phase of her life affected by me. And so I say that to everybody listening and to you of like, keep showing up because odds are the person that you help the most is the person you never even hear from or knew they existed.
Yeah, I mean, there's a lot of people online scrolling all the time, and they can live in small towns in the middle of nowhere, and you can help them. That is, I take those messages and I hold on to them super tightly too. I think another reason I wanted to come into this space is because I come to the table with, I'm just trying to educate, even though if you think my content does not speak to that, I'm just...
It does. It's fantastic.
Okay. But a lot of people will be like, I think a lot of the influencers in this space that are doctors like trying to make money off of certain things, which is why I've gotten a lot of criticism. Like, what are you doing here? You're not trying to make any money. Like, why? What are you doing? I'm like, I'm just educating, right? I'm not selling you surgery. If you come to me, I make no money if I do your surgery or we sit there and we talk. Like, it's the same amount of cash. So I think a lot of people are looking at me like, well, you're just trying to sell surgery with yourself. I'm like, I only take a certain type of insurance. You can't see me anyway. So again, they might have just woke up and decided to hate someone. But it can be challenging. I definitely have days where I look at my phone. I'm like, okay, not today.
Yeah.
Not today. Why am I doing this? I'm making no money.
Yeah.
I'm just educating. But I mean, it gives you opportunities. And I do get those occasional messages like, I live in the middle of nowhere.
Yeah.
No one in this town even knows what endometriosis is.
I think we all get that. I think there's just this idea that like you shouldn't be able to make money in something that's so personal to somebody. I own a supplement company, and it's interesting to me that I actually don't get that much hate for it, but there will sometimes be like, oh, you just tried to sell me your supplements. I'm like, really? Because I just told you all the foods to eat for magnesium. So I don't know. Like, I always tell you to eat nutrition first, but then I'll have people who are like, I didn't even know you had supplements, and I wish I would have known this because I just discovered it and it helped. And it's something where you're like, you have to be comfortable in who you are and what your mission is and what you're really trying to do at the end of the day. And I think that's something that when I entered into my 40s, and I've had like a really rough ride into my 40s of things happening, that I was like, I know who I am. I know what my intentions are. I know what I show up to do. And I know the history of my character speaks for itself. So someone might want to come online and paint me in a negative way. And people online tend to believe the first thing they hear, right? And never actually like look into somebody. Someone says like, oh, this doctor, like she's just a surgery mill. And so she just wants to make tons of money off that. There's going to be people that are like, oh, unfollow, you must be. And I'm like, it's sad to me that we are not teaching critical thinking in school, and it's something that I'm trying to do better with my kids, but also it's not my responsibility to prove my character to every single person that exists out there. Like, my actions have spoken. I have been very public for a decade, and I think at some point you just have to be comfortable with that of like, people are going to judge me either way. I've shown them who I am. Yeah. They can make their own decision.
Yeah, I mean, I've even had... there's a couple like content creators that do menopause that are really big into the menopause and like the hormone replacement therapy, and I follow them. And I've even gone into like large meetings with big groups of OBGYNs, like just for a regular meeting, and said, hey, I learned this from so-and-so online. And they're like, what? You're quoting this doctor from online? And that person has a supplement company, like obviously. You know, and it's just,
I think what doctors don't get taught. So my background is in nutrition science, and I learned a lot about the supplement industry. An OB-GYN has no problem prescribing a prenatal, but what they don't realize is that there's a lot of contaminants in that prenatal, and it doesn't actually even have what it says in it. And that was the big reason why I ever did my supplement company, because I was like, I'm pregnant. I want it third-party tested, I want it heavy metal screened, and I want to know what's in it. And I am going to contract with a pharmaceutical manufacturing facility, so it is at the pharmaceutical grade in doing that. And I think when people are like, oh, it's just like they're just trying to sell supplements, like, yeah, there are supplements that I see on Amazon that I'm like, I know how much those ingredients cost. That's not in the bottle. I mean, I have met people at business conferences who are like, oh, we put rice powder in our supplement and sell it to people. And I'm like, what? And they're marketers from some other country who think this is totally okay. And I'm like, this is wild. And that's there. So when you meet doctors who have supplement companies, it's often because they're like, I need to take this. I need to control this because it's so wild out there. But it's this idea that like, because there are some doctors who are like, all supplements are bad. There's no reason for a supplement ever. And then I'm like, well, what if someone has iron deficiency anemia? Oh, iron sulfate. Oh, the lowest quality iron so that they're constipated and they feel like hell. Or you could give glycinate, like highly absorbable, lower dose, going to raise their ferritin like faster. And you start getting into these conversations and you realize there's been no critical thinking. There's only been, I heard this thing from someone I respected, so therefore I just thought like, okay, this is just the way it is. But I know what you're talking about in the menopause space because I know some of these people because I remember them when they were like just stepping onto the space. And when they got popular is when other healthcare providers decided they were no longer a human. And that's a weird phenomenon that happens on social media is that once you have a certain number count, you no longer have to be treated as a human. For some reason, you can be dehumanized and hated on, and it's somehow okay. I don't get down with that psychology. I'm always like, the thing is that you have kids. I think about this all the time. My kids will grow up and they will see the history of my legacy of what I did online. And I never want them to see that I taught them to be kind, not to be a bully, and to treat people with respect while I went online and did the complete opposite. I'm like, no.
Yeah.
That's what I'm like, that is what on my deathbed would like, I don't know, keep me 1 foot out of the grave. I'm like, I don't know about this.
Yeah, I mean, I had like no coaching in this space. I just was like, I'm just going to start somewhere.
Do.
Right. I don't think a lot of people do. Like, and that's now people are like, well, you have $25,000. You need like someone to help you. And I do need help. But like, I don't know. I'm just kind of learning as I go and just trying to kind of go back to that same mission of like, I'm just trying to provide education in the space, make patients like see that we're not all like this. Like, there doesn't need to be so much like hate against endometriosis, like doctors and OBGYNs.
Well, gynecologists, man, people hate.
They hate gynecologists. It's crazy.
Some like definitely have like welcomed in that hate by being really awful humans to other humans who are in pain.
Yeah.
And I get that, but I think it's so important, exactly what you said, of like demonstrating that like it's not a whole field. It just happens to be that you've run into like some really unsavory ones.
Right. I mean, most of the gynecologists I know and I work with are really good people who want to help people. Like I don't come across like these people who show up every day and say like, I don't want to help these people.
Yeah.
I honestly think it's that we don't know what to do. And so then their ego steps in and they're like, well, just get an ultrasound and take the pill. Yeah, your ultrasound's normal. Have a great day. So I think that a lot of the hate that's come for gynecologists is just speaks to the large gap in education in the chronic pain and in the endometriosis space. People do not know what to do.
I always say no one went to medical school because they didn't want to help. They absolutely wanted to help. And the other layer in that is that insurance ruins everything.
Right.
It literally ruins our insurance, and the pharmaceutical company, they so wisely played the patients to say the doctor is the enemy. Well, they raked in all the profits, but told the patient that the doctor is just money hungry, greedy, all of that. I'm like, that's literally pull back the statistics of where money flows. And it's not the reality of it. But these big corporations sure did play us all against each other. Sure. I want to ask you, so for someone who's newly diagnosed or still searching for answers, what's the most important thing you want them to know about living with endometriosis?
I think that, well, I would say endometriosis will not or should not, it's not an automatic death sentence or life sentence. Like, there are ways to help. Is it perfect? No. But there are ways to help. And I think a lot of people feel like a ton of relief once they know they have it. But then also they go into this next stage, which is like, how am I going to live with this? What am I going to do? My whole life, it's going to change my career path and whether I have kids and all of this stuff. I think it comes with, the diagnosis comes with a lot of questions about your life path. But I think the one thing would be, there are things that can help. There are people out there that want to help you. It's just finding those people just feels like a little bit impossible of a health journey. So you just have to be persistent, and you have to have someone in your corner that can advocate for you. And surrounding yourself with those people, that's what I would say.
Wow, this has been such an insightful conversation. And I'm going to link to your social media so people can find you because you are funny.
Okay, promise I'm funny.
You make learning fun.
I try.
Well, thank you so much.
Thanks for having me.
Thank you so much for joining the conversation. If you could like, subscribe, or leave a review, it helps me so much in getting this information out to everyone who needs it. If you enjoyed this conversation, then I definitely want you to check out this.